talking about some different lab and tests that are needed in our profession and how they interact and how we need to know some of the lab values with our patients, more so pertaining to contrast media studies. So here we see a couple of them. We know that one of the important internal organs that we need to be aware of for some of our contrast media is the kidney, the renal system, okay? So what type of patients do you think we would need to be even more mindful of when it comes to their kidneys and its function? Correct, so patients that are on dialysis, because they already are at a disadvantage and they already have to have certain processes in place in order for their renal functions to be maintained. So when we have patients at a certain age or patients that are on dialysis, we have to look for certain levels, okay, in their renal function. And this is done either by obtaining a creatinine or a GFR. Who recalls what GFR stands for?
Is it growth?
So I heard somebody say the first one, glomerular.
Fraction ratio.
Well, the last one is ratio, so what's the F stand for?
Function.
No?
Filtration.
Correct, filtration.
Filtration.
So glomerular filtration rate is what our ratio is what we're looking for with the GFR. So that's a simple test that we can do with our patients. Typically it's a blood test, but now they do have devices that you can pretty much just do like a finger prick, and you're able to determine what the GFR is and your creatinine. Now there are some other factors that needs to be looked at when you're looking at the GFR. Normally we will, in order to get that number to make sure that the patient is within the range, we typically use the GFR calculator system. So we have to put in the creatinine, the patient's VU1. VU1's not up here, but what does that stand for? What type of lab test is that?
For the liver? Is that a liver function test?
Yes, but what is the actual VU1?
Nitrogen, yeah.
Right, so we enter in that information, the creatinine, also with some additional patient factors, their age, their weight, also they ask if it's a male or female, and also their ethnicity, okay, if they're African American, if they're white, if they're Asian, all of those factors need to be entered into that GFR calculator. There's numerous ones that are out there. Typically, most technologists just Google it or pull it up online, enter in their information, and it'll give us what the GFR is. Next, we have blood coagulation, okay? So these tests measure the patient's blood coagulation. So what type of contrast-related procedures would we need to do these tests for?
What, the PT? Wait.
So these four tests, so we have PT, PTT, platelet, and INR. So when we look at these, what type of tests typically would need these type of labs to be done?
What do you mean by what type of test? A blood test?
So when we do exams on patients, all of these lab exams that you see here on the screen, we don't have to do all of these lab tests or look at all of these lab tests for all of the specialized procedures we do. They correlate with certain ones. So for example, with the renal function, the first one we started talking about, what type of tests would we need to look at for those?
Kidney function test.
So kidney function test, and really and truly anything where we're going to be injecting intravenously contrast media, because that contrast media has to get filtered through the kidneys in order to be expelled from the body as waste, all right? So what exam do we do in our field that would involve that? where contrast media is administered intravenously.
Oh,
Well, that's not administered intravenously, that's gonna go through a catheter, through the ureter.
the IVU?
So either the IVU or the IVP. What does the IVU stand for?
Urinary.
So urinary, but what's the whole thing? Lauren, what are you saying? So IVU, intravenous urography or intravenous urogram. IVP is pretty much the same thing. IVP is intravenous pyelogram. Okay, so for our profession, X-ray diagnostic imaging, that's really the only field that we would possibly look at those first set of lab results are for one of those tests because the contrast is being administered intravenously. Now, these lab tests for renal function are done on a regular basis in patients that are having CT and also MRI because they have a much higher volume of contrast media being administered via intravenous with the patients. So then my next area, blood coagulation, all right? So these tests measure how the blood is clotting in an individual. So we have PT, PTT, the count for your platelet, and INR. So I was asking what type of tests would we be looking at for these types of coagulation exams?
Your blood? Your heart?
So we know this isn't going to be routine diagnostic, just regular X-rays. There are going to be more specialized exams. So what specialized exams have we talked about or have you come across that you think we would need to look at their blood coagulation? Catheterizations? Okay, what else? And catheterizations, it's a little bit more specialized because a lot of times we do that in we do that in interventional.
For us.
And some of y'all should know this because some of y'all been comped on these exams. So this is something that you should have been checking before you comped on the exam
Renal
with the
function,
patient.
yeah, but I can't think of anything for blood. Because I don't think anything
If you put
is.
the contrast for the
Oh, probably like the
myelograms,
myelograms.
you will see how it goes for the body, and you can see also where.
Cause you going in there with that needle. Probably
Yeah.
like myelograms and lumbar,
Yeah. So myelograms, lumbar punctures, definitely need to check those lab exams, okay, for blood coagulation. So before you even have the patient come down to the department, you should be looking at those lab results, checking with the nurse to find out what those lab results are. If the patient did not have those lab results done, they're gonna need to be ordered and checked before the patient even comes down to the department, because if the patient is out of range, then they're more than likely not gonna be able to have the procedure. All right? And then there are a few others such as D-dimer and LFT, but again, those are gonna be for your CT, MRI areas, not so much us. So we spent a little bit of time already talking about the renal function and why we do it, okay? The type of exams that we're looking for with that particular lab test. So again, for diagnostic radiology, we're looking at it primarily for when we're doing our IVU, intravenous urogram, or IVP, intravenous pyelogram, all right? Because we wanna make sure that that contrast media that is being injected intravenously is able to be eliminated through the waste, okay? Contrast media is not good to just be stay in the body long term, so we've got to make sure that it is being properly gotten rid of. Patients that are on dialysis, we typically will schedule any intravenous contrast media exams around their dialysis, all right? Because we know that not all patients have dialysis every day, depending on how severe their renal function or renal failure is. Some have it 3 days a week, some have it every other day, some have it every day. So you wanna find that out, what's their routine protocol for having dialysis, because you don't wanna have them come down and have a contrast media exam on a day they're not having dialysis, and then that contrast media is in their system even longer before they get to dialysis. Typically, we will do contrast media exams the same day the patient is scheduled to have dialysis. Usually, they oftentimes will go straight to dialysis from our imaging department. All right, so some of the areas that affect renal function, or they have a higher risk, is diabetes, heart disease, and family history of renal disease. When we look at the creatinine, so again, in order to find out the GFR, it's a combination of utilizing the creatinine lab value and also the patient's BUN. So this is the range that we're looking at for that creatinine level. Okay, usually it's going to be between 0.6 and 1.2 milligrams. So we kind of talked about this. If the creatinine levels is out of range or the BUN is out of range, then more than likely your GFR is going to be out of range. So usually when we see those initial lab tests first, we're going to be able to determine, oh, this is a red flag. More than likely, once we enter all of the other data into the system, that patient's GFR is probably going to be out of range. So here is the breakdown of our GFR. All right, so again, glomerular filtration rate or ratio is what this stands for. And those two lab tests, in addition to some of the patient's biographical information, is entered in order to compute this number. All right, you can just look up if you ever had to do this. We don't really use this a lot in our field of radiology. It's more so in CT, MRI, but if you ever have to look it up, you could just Google GFR calculator, and we usually use the one from the National Kidney Association is the one that most technologists utilize to enter into the information. For normal limits with the GFR, the range, it's going to be between 90 to 20 is the number that we're looking at. Different factors is going to impact this number. So again, that's why we have to enter the patient's age, those lab tests, because all of that is going to impact what range they're going to fall in. If they're below or above the normal range, more than likely the patient is not going to be able to go through with the procedure, at least not that day. They may reschedule it for a few days out. When you see any GFR results that are 15 milliliters per minute or low, that is a sign of kidney failure, and 60 is a sign of anything 60 or below is a sign of some type of kidney disease.
What'd you say, 60 and below?
60 below is going to be a sign of some type of kidney disease, and if they're 15 or below, it's going to be renal failure.
Oh, Jesus.
As we see that the normal range is starting at 90. For the BUN, all right, so again, the BUN in combination with the creatinine levels is what helps to formulate that GFR number. BUN, blood urea nitrogen, okay, normal values for that is going to be between 7 to 20 is the normal range that we're looking for. Looking closely at our tests involving our lumbar punctures, myelograms, again, that's going to be your PT and your PTT levels, okay? Here are the ranges for those, and the reason why it's important to look at these areas is because, again, those lab values have to deal with the patient being able to clot. You're measuring how their blood is functioning and their clotting ability. And since the lumbar puncture and the myelogram is going to be in the vicinity of the spine, we want to make sure that the patient is going to be able to clot in that region and there's no excessive bleeding since we're coming close to that spinal canal and in the spine region. All right? So you can see the normal range for both of these at the bottom of this slide. If the patient is out of these ranges, again, they more than likely are not going to be able to have the test done that day, and they may have to reschedule it for another day during the week or the following week once they get those levels in check. So how many of you have actually comped on, I know some of you have, but I just don't remember who, a myelogram or a lumbar puncture? I know for sure at least two of you guys have.
I think I did.
Okay, so do you remember what else they look for with, not so much what they look for, but what else is important for those patients before they come down outside of looking at these lab values? Typically, there's a medication that sometimes patients are on.
Blood thinners.
I'm sorry, that's right, I just jumped to your question.
Thanks,
Um,
So that's right.
But yes, blood thinners. So that's another thing that's important that you wanna check for with those patients. You wanna make sure that if they are on blood thinners, that you have the nurse, have the doctor put a stop to that 24 hours before they come down for the procedure. So that's really important. All right. So next we're gonna go into some common medications, pharmacology before we start talking about specifically contrast media and some terms that you wanna be familiar with contrast media. So with pharmacology, these medicines that you see listed here are typically anti-inflammatory medicines. So we have aspirin, Advil, all right? These involve non-steroid type of anti-inflammatory drugs.
What slide is that?
114. Then we have drugs that assist in suppressing the immune system. All right, so Solumedrol, any type of steroids, prednisone. So those type of medications will more than likely be administered for any type of allergic reaction. A lot of times if patients have a known allergy, especially to iodine, we typically sometimes will pre-medicate them based on their history of what type of reaction they have with that allergy. And a lot of times we will pre-medicate them with Solumedrol. And when I say we, I don't mean us directly, but we will have that communication with the nurse and make sure that the patient is pre-medicated and they have a certain protocol that will follow before the patient comes down for their testing. Then we have our pain relievers and anti-anxiety medications, all right? So opiates, and we're gonna see that as Demerol, Dilaudid, morphine, those are all heavy pain relievers, narcotics. For anti-anxiety, a couple are listed here. So pretty common are Ativan and Valium. Those are some popular ones as well. When we're looking at the definitions for these different medication categories, you can see them here. So this is important to know. Anesthetics, okay, so that's going to be lidocaine or xylocaine, so we want to numb areas, and we use that pretty commonly, especially in our lumbar punctures, myelograms. I think that's one of the specialized exams that we probably will use this on a regular basis because we want to numb that area before the radiologist or the neurologist goes in with that needle. Analgesics, so again, those are going to be our opioids. Sedatives, so we have fentanyl and Ambien, so patients that are irritable, having a hard time to sleep, you might see them on those type of medications in order to help with that. Or if they're restless or they're being combative, again, those patients might be administered some type of sedative. And then we already talked about the anti-anxiety type of medications. So we talked about blood thinners for some of our exams that we want to be mindful of. What is a type of medication that affects blood thinning? Do you guys know what they're called?
is it Cumberland? Cumberland?
Yep, so here is our medications, for patients that need to be on blood thinners. They're having, either issues with having a lot of blood clots. Usually they're placed on blood thinners. Ideally, blood thinners are not intended to be taken for a long, length of time, okay? It's supposed to be taken for a short length of time. So patients aren't like to be kept on that because you're thinning your blood. So if you do have a potential injury, you have the risk, a higher potential of potentially bleeding out. So those patients are monitored very carefully for being on the blood thinners. Then we have, what about our diabetic population? What type of medication are they given?
Metformin, insulin.
So we know that there are different types of diabetes. A lot of those patients are going to have metformin as a medication. There are some times that they would ask for some of our contrast or fluoro exams, upper GI. Sometimes they do hold the metformin. Usually it's like the morning of. So just make sure if you have a diabetic patient that's coming to you and they have, more than likely they're gonna be on this type of medication or some type of diabetic medication, you wanna make sure that you communicate to that nurse for your diabetic population. Because usually when they come down to us for their fluoro contrast related studies, they're with us for a while, okay? I mean, just the process of them getting down to us, getting into the room, being questioned, checking their history, getting the scout film, communicating with their radiologist, that's at least like 30, 40 minutes, all right? So they're with us for a while, not even involving the exam time. So when you're done with those patients, especially if it's a small bowel, we know how long those can take sometimes, you definitely want to make sure that you communicate with that patient's nurse before they go back up to the floor, all right? Because when the patient goes back up to the floor, transportation system take them back to their room, drop off the chart. They may or may not let the nurse know the patient's back. And you don't want that patient sitting there for another hour and they could potentially be put back on their medication or have gotten their diet resumed. So make sure that you're doing proper handoff communication with the patient's nurse. What was the communication that we talked about last week? What was that called?
S-bar.
Correct, so that is SBAR. All right. So now let's do some reminders for our contrast media. All right. So why do we use contrast media?
So we can see what we need to see on the X-ray imaging.
Okay, but we can see some structures on X-ray imaging.
Right, it brightens it up.
It enhances it.
So what specifically is it enhancing?
The bowels, the colon, stomach, esophagus.
So correct. So what system does that fall in line with? So that's our digestive system.
Digestive.
Jasmine, what did you say? So, well, not so much muscular, it's more so gonna be our internal organ systems, okay? So our urinary system, our digestive system, central nervous system with the lumbar punctures and myelograms. What's the system that's involving the liver? Because we do ERCPs and cholangiograms, more so like in the surgical suite sometimes, or the endo room.
Yeah, that's what I mean.
Correct, so that's, endocrine for our liver and gallbladder. So have you guys? Yeah, so we've got the liver, the gallbladder kind of sits next to the pancreas, and sometimes those patients, if they're having issues with the gallbladder, we're gonna take them either to surgery, depending on where you are. Sometimes they take them to the OR to have the gallbladder removed, or if they have stones, they'll go in and remove stones. Or sometimes they just have like smaller dedicated seats for those type of patients. Okay, but typically we're going to inject contrast media for those type of exams. And what are we able to see when we inject contrast media?
The highlighted anatomical region we're looking at.
And do you remember specifically, like if we're doing the gallbladder, some of those major vessels that we're able to see with the contrast media that's highlighted?
What, the common hepatic duct, and you talking about those?
Mm-hmm. Yep, so you've got your bile duct, your common hepatic duct, they're gonna branch off smaller and smaller, so usually, the surgeon likes to see all of that with the contrast media to make sure that there's no blockages, because a lot of times patients that do have procedures involving that area, they have stones, and they wanna make sure that a stone has not gone into one of those vessels and, may have obstructed it or blocked it, okay? So contrast media, we're able to see internal structures that we typically can't with just our regular x-rays, okay? Because usually with our regular x-rays, we do see internal organs to a certain extent, more so shades of gray, but contrast really enhances those features. All right, so what are some things that you guys remember about contrast media?
Positive, negative.
Right, so we have positive and negative, okay? So give me an example of a positive type of contrast media.
Barium,
Okay, and what would a negative be?
air.
All right, so you guys remember those when we were reviewing contrast media? We have two main types, positive and negative, and sometimes we use both of them. Okay, give me an example of a study that we use both positive and negative contrast media.
Contrast, barium.
Mm-hmm. So not just barium enema glomerula, but a double contrast
Yes.
barium enema or a barium enema with air. That's going to use both positive and negative contrast media. So with our positive contrast agents, those are going to have a higher atomic number than the negative, okay? Because the negative is just typically air. And they're going to make the internal structure, the internal organ stand out a lot more as opposed to the negative. Again, I asked for some examples. So specifically barium, okay, some ionic type of contrast, those are all going to fall under positive contrast media agents. When we look at specifically iodine-related contrast media, again, they have a higher atomic number. These are going to be filtered through our kidneys. So again, that's why we want to make sure we're checking those labs, especially if it's being injected intravenously. And they're water soluble. Is barium water soluble?
No.
So no. So barium's going to have a harder time being broken down.
Hey, good morning. I'm sorry.
That's okay.
There is a red Hyundai parked at the front. Is that anyone car here? Red Hyundai.
No.
Oh, thank you.
Okay. So when we look at the breakdown of how these molecules appear in the composition of the contrast, we can see a few changes or differences. With ionic, they are going to dissociate in the blood by using two particles for ionic type of contrast media. Non-ionic does not dissociate in solution. When we look at our monomer types of contrast media, those have one benzene ring, while dimers have two. And trionated goes along with its term, and we're going to see 3 iodine atoms per ring on there. Okay? So remember these images. So this is an example of a molecule that is ionic. And specifically, would this be a monomer, dimer, or tri-ioninated?
Try.
So this is going to be tri because we can see
3 ions.
the 3 iodines on the one ring. Okay? So make sure if you kind of forgot about the breakdown of contrast media and how it appears in a molecule form, you guys go back and look at this. When we look at non-ionics, okay, these easily do not break apart. And they're going to have more iodine atoms per molecule. There's usually going to be about 6 of them.
The one that we were on like 2 ago, can you tell me what slide number that is? I can do that.
Let me just make sure it's the one that you're talking about. This one?
No, I think that one. Yeah, the
This is
turn.
124. Alright, so non-ionics, they don't, they easily do not break apart, and those can be broken down into further areas. Most of them are going to be classified as a monomer, but we do have some one contrast media that we utilize sometimes, which is a dimer. So this is a quick chart that you can reference that looks at the breakdown, and it has both on here ionic and non-ionic. So you can see the ionic types of contrast media at the top, and we've got both names, okay? The common name and then the generic name. So we're going to be more familiar with these terms that are in the parentheses, okay? That's what we typically go by. So out of these 3 types of ionic contrast media, the one we utilize the most is going to be isopaque, and that is a monomer type of contrast media.
So what is the difference again between monomer and dimer?
So the amount of atoms we're seeing on the ring. So when we look at the monomer, okay, there's going to be 1 benzene ring, and the dimer has 2. With the triiodinated, we're going to have 3 iodine atoms on each ring. So going back, looking at our non-ionic compounds at the bottom, okay, again, the terms that we're most familiar with here are the ones in the parentheses, and out of these lists, which ones have you guys interacted with or are you familiar with?
Omnipaque.
All right, so good. So I heard Emma and Takosha say Isoview and Omnipaque, and that's correct, all right? Sometimes we use Visiapaque as well, which is a dimer, but these are all contrast medias, and a lot of times we use those heavily in our urinary system. So Lauren had mentioned earlier about the retrograde. These are the type of contrast that we're going to use for that type of procedure. Either a regular cystogram, a cystogram retrograde. We're going to be utilizing either Isoview or Omnipaque for those type of exams. So you always want to check with the radiologist. They're the ones that pretty much drive what contrast media to administer to the patient. But as you guys work in the field and you get more familiar with the procedures and specifically your radiologist, you're going to have an idea of what they like to use or what their go-to is. So that way, but you always still want to check before you actually administer it to your patient. So now let's talk about contraindications. Who remembers what that means?
The who?
Contraindications?
Oh, the adverse effects.
Adverse effects to what?
The contrast media.
Mm-hmm. So give me an example.
Sounds like another.
Well, not the reactions. We're going to go there next. But what type of patient might we see, or what type of patient would exhibit a contraindication to be given contrast, some type of contrast media?
Someone with like a perforated bowel.
Mm-hmm. So someone with a perforated bowel. So let me hear from someone else. And we have an individual with a perforated bowel. What contrast media would be a contraindication to administer to them? So with the gastrografin, are you saying that we should use that or we should not use that?
We should use that.
Correct. So for an individual that has a perforated valve, we want to use gastrografin as a contrast media as opposed to barium, because the gastrografin is water soluble. And if we don't know if the patient has a perforated valve when they do, and that contrast media leaks into their cavity, it's much safer for the gastrografin to leak as opposed to barium. And remember, barium is non-water soluble; it doesn't mix. indications that we can see that are common to our patients. Again, renal failure. So that's we wanna, sorry, that's where we want to make sure that we're checking the renal failure, because if the patient lab values aren't where they're supposed to be, if their GFR is not where they're supposed to be, we're not just gonna go ahead and continue to administer that contrast media to the individual, because we wanna make sure that we're being safe and that patient doesn't have a type of reaction. Dehydration, okay, that's another important area that you wanna pay attention to, because one, if the patient is severely dehydrated and they do not already have an intravenous line and they're coming down for that type of study, we may not be able to access a line to administer the patients intravenously to them. We talked about nephrotoxicity, so how their kidney function is doing. We want to make sure that patients that have any type of damage to the kidneys, they're well hydrated before and after the test. And then one common one is just being allergic to iodine, okay? If they have an allergy to iodine, we looked at one of those medications earlier on. There are certain protocols that have to, the patient has to undergo if they are to have the procedure done, all right? So we want to pay attention to all of those contraindications. And then also the example that we talked about earlier with what are we looking for? What's the disease process? What's the best contrast media to administer based off of that? So a way that we can prevent nephrotoxicity, again, is making sure that the patient is properly hydrated, okay? Especially for our renal failure population, or our patients that have renal disease. We want to make sure that they are drinking plenty of clear fluids before and after the procedure is done.
Miss Hipper, I got a question.
Mhm.
When we talk about all these lab rooms and we're watching them, do they overall have the ordering physician looking at this, or is it our job to stop if we see the ranges are not within range? You know what I'm trying to say?
I mean,
Because I know we
typically-
have a special role that we can say, no, we can't do it if they like. But aren't they supposed to be looking at that first, or
they are, but like more routine exams, like our GI exams,
we just have to pay something?
which is more so going to probably impact like our diabetic population that's coming to us. So that's where you might have to have their metformin held and stuff like that. The doctor ain't gonna
So
be
just
checking
make
for
sure
that.
that you, okay.
They may be more involved with the lumbar punctures and myelograms, just because that's a more involved case and it's more critical for those things to be checked, because you're dealing with the patient's spine or in that region. But we still need to, never
Yeah.
make that assumption. We still need to make sure that.
So we would just call them and say that their values are off?
Yeah, we wouldn't call, typically we don't call the doctor directly. Usually we communicate that through the nurse.
Okay.
And then the nurse calls them, but sometimes you might have a nurse that don't, work with you too friendly, and they're like, well, I don't have time for that, you call them.
Okay.
And then, we already have the patient sometimes down with us, so we'll just go ahead and reach out to the doctor.
Okay. I just wanted to clarify. Okay, thank you.
And sometimes the nurse, some nurses are aware of the labs too, that are important for these various tests,
So they'll
sometimes-
say their labs is off.
Right, but sometimes they have no idea, and the patient hasn't even had the lab work done yet, so. All right, so proper hydration. So let's look at some of the possible reactions to contrast media, okay? There's different levels of reactions that we can see, and and this is important, because some reactions with contrast media is normal. Just because the patient is having a reaction, that doesn't mean it's a bad reaction. We know that when we administer a contrast media intravenously, typically the patient is going to have a warm sensation over their body. Sometimes they feel like they need to urinate. Sometimes they have a metallic taste in their mouth. So all of those are normal reactions to have. The ones that you see up on the screen are abnormal reactions, and we have them in levels or different grades. One being a minor form of reaction, and then grade 3 being a higher level where they can possibly go into anaphylactic shock, which is what we don't want to happen. So you really need to make sure that you are watching for potential reactions. And again, these reactions, typically if the patient is going to have one, it's usually for medication that is administered intravenously. All right, oral consumption of contrast media typically does not result in any type of reactions. The same thing if we have to do any type of rectal administration with our barium enema studies. It's usually intravenous exams that's going to have a type of reaction.
What is emesis?
Vomiting.
You also want to make sure that if you have a patient coming down for an IV related contrast, you definitely want to make sure you're aware of the where the crash cart is, because God forbid if there is a severe or a level 3 grade reaction, that patient might go into heart failure as a result of the anaphylactic shock that they experience. So you want to make sure that you're getting that crash cart coming to that patient as soon as possible. Some areas or some risks that increase these factors is allergies. Again, we do communicate and verbalize to our patient and get a good history, but if the patient has never had that type of exam before, they may not realize that they have a potential allergy to it. So you want to make sure that you're paying attention to that. So sometimes we kind of ask, although if they may not specifically know if they're allergic to iodine, we we could tiptoe around that question and ask them, hey, are you allergic to shellfish? Okay, because that's kind of in that family. So sometimes we could get an idea by asking that question as well. Asthma patients, all right, they have an increased likelihood to have a potential reaction when administered IV contrast. So you can ask that as a part of your history when you are interviewing the patient. When you do inject intravenously, and again, in our specific field of diagnostic radiology, we pretty much only have the one urinary study that we are administering contrast media intravenously, which is our IVU or IVP. So it's not, and even that is kind of becoming a little bit obsolete. So we're not doing IV related exams all the time, but I know not all of you guys are planning to just remain in diagnostic radiography. How many of you guys are planning to go on to other modalities such as CT or IR or MRI, right? Because you want more money, right?
Mm-hmm.
And not as physical or strenuous on the body too. So definitely IV stuff all day long, all right? Much higher percentage of your patients coming in to have IV related exams. So when you have your patient come, a lot of times the patient's already going to have an IV. Unless you're just working like in an outpatient center, then you're gonna for sure have to put it. But you wanna make sure that you leave that IV in place. Typically, we leave it in place. I mean, the slide's saying 5 minutes. But usually we leave it in place for the whole continuity of the exam, okay? And we only remove it once we have the radiologist's approval, because sometimes they might want something else. And if you already took the IV out and they might want, to administer a little bit more contrast, now you gotta do a whole nother IV on the patient. So usually we will check with the radiologist, make sure the patient is free to be discharged, nothing else is needed before we remove that IV. So typically it's going to be there for the entirety of the exam. Obviously if you're doing a hospital patient and it's an inpatient, you're not removing anything. You just access their IV and then you're sending them back with the same IV. For severe reactions, okay, you want to make sure that once you see a patient is experiencing symptoms that are a little bit more on the severe side, you want to react right away, okay? Some of the milder reactions that a patient may encounter is going to be a rash, maybe itchiness to the site, but one of the more severe reactions is going to be the patient profusely sweating, they may turn pale, they may start to have difficulty breathing. Okay, all of those symptoms are on track for a severe reaction. So you want to make sure that you alert somebody right away, and You are also potentially making sure you know how to initiate a code response, just in case the patient does become non-responsive and they don't have a pulse, you can initiate that relatively quickly. Typically, if a code is called, you also want to make sure that you're getting the crash cart to the patient as soon as possible. So those various medications that the doctor needs to administer to the patient is there. And most importantly, your defibrillator, all right? Because we know our defibrillator is going to typically be sitting on the crash cart, so that's important to get there as quick as possible. Again, patients that we know are prone to have a reaction or they have had reactions before, we can pre-medicate these individuals typically depending on what type of exam they're having or how much contrast media they're going to be administered. They are pre-medicated anywhere 24 hours to 48 hours before the exam. Some institutions do have an emergency type pre-medication and it's shorter. It's like 4 or 2 hours, like if the patient really needs to have that test done, and they can increase the pre-medications or the antihistamines that the patient is going to be receiving. So make sure you follow whatever your patient, your hospital's entity procedure is pertaining to that.
I was just looking at that previous slide where you're talking about the code. At the bottom, you're just talking about like, your hash mark, the epinephrine and the nasal the atropine. We don't do that though, right?
No, so
It's
that's
just on there. on the
yeah.
side.
So all of that, all of that medication will be on the crash cart, and those are typically the medications that would be used in the event the patient coded. But yeah, we don't just go and take it upon ourselves to administer that. One, it has to come from a doctor's order, and typically it'll be the nurse that's a part of the code team that will administer those medications. How many of you guys have, in your sites that you've been so far, radiology nurses that are in the department?
They're in like CSU, well, they're in like that, they're in, like, are they usually like dressed out like in the hospital sort of, cause they're in like that pre-procedure room, is that what you're talking about?
Mm-hmm.
Yeah.
So where's that at?
I think it's called like the clinical support unit, they're like, they do all the like IR stuff.
Oh, okay.
They do all like the floral
Mm-hmm.
pre-procedure stuff, is that what you're talking about?
Mm-hmm.
Yeah.
Yeah, because I know that not everywhere has dedicated nurses in the imaging, but if you do, that's great because you don't have to worry about a nurse, coming from elsewhere, because typically there are going to be the initial ones there that can help in the response. So extravasation, who remembers what that is?
So when you burst the vein.
You're
Oh,
on the
when
right
it
track.
bursts. IV burst, the IV,
And then
That's the one
it's like
leakage.
what do you call it? Well, I call it something else. Infiltrated.
Yeah, so you
Yeah.
guys kind of all together, all those are right. So the vein is blown or burst, and while you're administering contrast media, so our intention is for that contrast media to go through the vein, but now that there's an issue with that vein, right, it's blown or it burst, that contrast media is all going into the patient's tissue, which is not good, all right? So that is what extravasation is. And there's different levels of extravasation as well, depending on the amount of contrast media that went into the patient's tissue.
Is that,
Mhm.
would that be different, like, one of the people we had to do a vocal on, they were trying to put a chest tube in and they missed, I guess, like it was filling up her body instead of her lungs, is that still considered extra?
Extravasation.
extravasation?
I mean, it could fall under that same term because it's the same, process that's happening. It's just with a different tube and a different type of body, but yeah. So when we look at it for our patient population, again, it's gonna be more, critical for the patient, the more contrast media that they're receiving, the more dangerous it's going to be for the patient. So let me give you two scenarios. If we have a patient that is coming to us and they are having, they're scheduled for IVP, okay? And they are being administered, their contrast media for the IVP. And we have another patient who is going to CT for a CT of the abdomen with contrast. Both of these patients, veins blue, or the IV side blue. So now they've both experienced extravasation. Which one is gonna be a higher risk of having more damage than the other? The one that is in CAT scan or the one that came to X-ray for the IVP?
IVP.
Okay, so why do you say that one, Tanya?
Because it's higher, they're using higher radiation in there, right?
They're using higher, I'm sorry?
They're using higher, it's more over there.
Mm-hmm, right. So the CAT scan is going to administer a higher volume of contrast media, and also their volume is more forceful, all right? I don't know how many of you guys have had to see CAT scan, and this is actually the semester that you're gonna really spend time in some other modality areas, but they actually use a machine to push that contrast media into the patient. So it's going at a high rate of speed, and it's a larger volume than what we're doing with our IVP population. Because IVP, we're pushing it by hand.
I'm about to say, we do a slower push, we do.
Mm-hmm. Right, and the volume isn't as much. So that's way more dangerous for CT versus patients that come to us. Typically, if a patient does have an extravasation, you're gonna know right away because it hurts. And they're gonna be yelling and they're gonna say, ow, ow, it's hurting, stop. And that's the first sign, typically, that you know something's not right. So if the patient is communicating that to you, you definitely wanna stop right away, okay? And these are some things that you could do initially. You're gonna alternate applying cold and cold compresses to the site. You wanna elevate the arm, okay? Contacting a surgeon is usually towards the tail end of things, depending on how far the extravasation has spread to the individual and how it's impacting the tissue. One thing that's not listed on there that you wanna do is notify the radiologist. All right, because the radiologist is typically gonna come and look at the patient. They may indicate for the patient to receive certain medications, and also it's good to have some type of marker or Sharpie to outline, because when that happens, usually that area is gonna swell, okay? So you wanna outline that swelling so that way it can be monitored if the extravasation is going beyond that point, if it's continuing into the tissue. All right, so these are the initial steps that we will do with the patient. You definitely want to communicate to the patient to follow up with their doctor, make sure it's monitored, because it can get worse. And you just don't want to not have it monitored or treated, because the patient can actually need to go to surgery to get some of that tissue removed so it's not continuing to get damaged by the contrast media. All right? All right, so now let's talk about some of the ways that we administer our contrast, and we're going to get into some of our reminders about venipuncture, some important things with administering medication intravenously, and then we will probably take a break. When we come back from the break, we'll talk about infection, important reminders about infection, and we'll end with sterile technique and reminders with sterile gloves. All right, so administration routes. So we've talked a lot about IV administration so far, but there are all other types of ways that we can administer medication or even contrast media. All right, so we have parenteral. The two main differences is parenteral and then enteral. All right, so parenteral is going to involve a needle catheter or angiocath. Enteral is going to be either oral or rectal, okay? Now, with parenteral, what are some of the specific ways that we can look at for parenteral.
What you mean? Specific
So-
ways?
Remember when we did venipuncture, we had different types of needles because they were used for different types of route of administration, medication being administered to the patient. Everything wasn't just intravenously, right? Because we don't, sometimes, how do you guys get your flu shot?
Yeah.
Intramuscular.
Oh, you talking about intramuscular, subcutaneous, and
What about the ones for the
the
PVD
veins,
skin test?
yeah, under the skin.
Mm-hmm. Yep, so when we're utilizing needles, all right, there's still, that's even, that parenteral term is broken down even further. We've got intravenous, intramuscular, squamous,
Sub-Q.
and then intradermal.
Intradermal.
So, who can give an example of where sub-Q or subcutaneous would be utilized? Oh, sorry. Not TB. Which
That's
one?
the fat.
What is TB? Which one falls for TB?
Intradermal.
Intradermal. I have to stay on this side.
Intramuscular is shot right here.
So, which shot you guys have to have would be intramuscular? The flu shot.
That's like 90 degrees.
Yes, and remember the angles are going to change depending on what method is being utilized. With squamous or subcutaneous, I should say actually, that's more.
This one?
Mm-hmm.
So,
Yeah.
I did like this, okay.
So that would be like your diabetic population, when they're doing their insulin, that would fall in that range.
Okay.
Also, when we were doing venipuncture, okay, we know that needles come in different lengths and diameters, all right? When we're looking at the diameter specifically, what term is used for that?
Gauge.
Mm-hmm. Yep, so if I have a 22 gauge needle and a 14 gauge needle, which one has a wider diameter?
14.
Correct. That's a huge, right? Nobody wants to get stuck with that. So, you've got different, and you've got different gauges on your needles in addition to the length. So the lower the gauge, the wider in diameter that needle is going to be, all right? Typically, and I haven't really been in contrast media, but we used to like to have nothing, especially with CT and MRI, they used to like to, 18 was like our go-to number as far as the gauge size, because we know our contrast media is not very thin, it's got some consistency to it. So we wanna have something that's got a good size diameter to help that contrast media get through to the patient. So usually 18 would be our go-to number for our patients with IV. We wouldn't want anything larger than an 18 because now that diameter is getting smaller. Definitely can't do nothing with 22s or butterfly needles. They're not gonna cut it for our type of contrast. We need an 18, all right? At least. So here is a quick little chart, okay, that's referencing the various sizes and diameters so you can see them, all right? But this is specifically for our catheters. So with our catheters, it's a little bit opposite to our needles, okay? For catheters, the smaller the number, the diameter is going to be smaller. So if we have a pediatric neonate infant that's 2 weeks old and coming in for a cystogram, okay, and they're 5 pounds, would we more than likely use a 6 French catheter on that individual or a 26?
6.
So it's gonna be 6, all right? We wanna use that smaller catheter because the baby's anatomy is much smaller, especially if they're a pediatric neonate that's preemie, okay? We talked about, I just mentioned this, okay, as far as how our contrast media has got some consistency to it, all right? So the correct term is the viscosity. It's not just very thin, free flowing like water. It's thicker, all right? when we look at viscosity on a closer view, or closer up, that is going to refer to the resistance of the fluid being moved. Alright, so our contrast media, it doesn't move very well, so we know it has a higher viscosity. This is more so as a FYI, because again, this is out of our scope of practice, but it's in, just so you guys know or remember, when we look at the flow rate, what is that pertaining to, the flow rate?
How it flows in, like the contrast media flows into the body?
So, correct, but what type of patients can we see that measured on? Because with our contrast media, we're just like pushing it by hand, or it's going to be auto-injected through the machine. So, the flow rate, we could get it from the machine.
Okay, the flow rate, is that the proton, the PT, is that what or no? Not really.
Not quite.
No.
Like, what patients come to you guys, or do you interact with, and they're set up with a flow rate, and we can't change that flow rate?
Oxygen.
Oxygen is one, okay, and what's another area that they come to us, and they're on a flow rate?
Oh, like your the chest.
Not quite, Jasmine got it, the drips, they're IV, they're IV drips.
Yeah, we
So usually their IV is gonna be going through a pump, and that pump monitors and controls the flow rate. How much milliliters of that medication or that solution is going in over a certain time. So we can't change that, and really and truly, you shouldn't be discontinuing that or taking the patient off of those drips or oxygen when they come to us. We need to maintain that continuous, all right? Now, if we do have to stop it momentarily to administer our contrast media, that's fine, but you need to make sure it resumes. So it's important to monitor what that rate is, okay? And if you're in an area or a department where they have nursing, they can assist with that. So the flow rate can be impacted by these various areas that we see here. Viscosity, again, how thick is the solution? How free flowing is it going to be? The diameter of the cannula or tubing, all right, is going to impact the flow. The temperature of the contrast. So have you guys come across any contrast media that needs to be at a certain temperature? You probably haven't, just because, again,
They keep them stored at
don't they
room
always
temperature.
store it at a certain temperature?
I don't
yeah,
know.
typically it's stored at room temperature, but there is one contrast media that sometimes you'll see placed in a warmer, is what it's called, and that is for our IVP and IVU. But again, they are kind of doing away with that because we don't do that exam a lot anymore. But we used to have the syringes, the pre-filled syringes with the contrast, just sitting in like a little mini warmer in our department, and to maintain it at the certain temperature. And then pressure applied to the injection. So we talked about administering contrast media by hand or with the use of our auto injectors, which we'll see in CAT scan and MRI. And that's going to be administered at a much higher rate. So when we talk about the flow rate with CAT scan and MRI, those exams are really critical to pay attention to. Make sure you're timing your exam in coordination with the auto injectors, because that contrast is going to move through the body fast, okay? And you don't want to miss it going through a certain organ. So you really need to pay attention. When we're doing our IVPs, do you guys remember what type or what part is going to start to enhance initially? That we term the blushing phase for our IVPs and our IVUs. Yes, but specifically what part of the kidney? So remember, we kind of broke the kidneys down.
You said IVUs, like the ureters or the bladder?
Well, it's going to highlight all of that, but which phase is gonna, what part is it gonna show first in the kidney? And we typically term that the blushing phase.
Oh,
I feel like we had this on a test question.
You said, what'd you say, Jasmine?
I saw the name every part of the kidney, the cortex, the medulla, the pyramids,
no, the renal,
the nephron.
Hold
it's,
on, let me
it's up
tell you.
at the top, whatever it is. I can't remember.
What is it, that little thing that sits on the outside of here?
You talking about the helium? The helium? Jasmine?
I wanna show you guys what I'm talking about. I'm gonna have to look some more because I don't like this one. It's not showing it as well. But this is an example of our IVP or IVU. So it'll more so be the papilla region of the pyramids out here is what is gonna enhance first, and that's what we call the blushing phase. So we gotta make sure our receptor, our cassette is everything lined up, ready to go, because pretty much as soon as you start injecting, that's gonna start to showcase. Once you finish injecting that first tube, it's gonna start to highlight that region before it even gets into the renal pelvis like we're seeing here. It's gonna be more on the outer part of where the pyramids are. Alright, so that's what we refer to as a blushing phase. Then it's gonna start to fill, as Jasmine was going through all the anatomy, the major and minor calyxes and the renal pelvis, and then it'll start to filter down into the ureters and down to the bladder. So with our contrast administration, we want to make sure that we get the timing right, and that's even more so critical with CT and MRI just because it moves so much faster. All right.
So the blushing phase is the filling of the what was it?
The pyramids. The pyramids, and you'll have like the papilla house in the pyramids as well. Alright, so the last thing I wanted to talk about, okay, so when we're doing utilizing ironated contrast media for our various procedures, if you use a larger amount of contrast media, that is going to allow for a brighter visualization of the internal structures or internal organs. It's going to be more enhanced, all right? So that's why we kind of have our set protocols on how much to administer, because we want to make sure the radiologist is able to adequately see those internal structures. So we don't wanna give them too little. And also, if we utilize a larger amount of contrast media, it's gonna keep that area enhanced for a longer length of time. So that's actually leads into an example of another contraindication, is having multiple contrast media studies on the same day or even within 2 days of one another, because there may be residual contrast, okay, from a previous study in the region that we're trying to look at. And the radiologist may say, oh, let's wait another day, let that contrast clear out some. So all of that's going to be directly related to the amount of contrast media that was administered to the patient. The less amount, it's gonna be able to come out of the system quicker. All right? So any questions on what we talked about so far? Okay, so let's take, it's 10:18, so let's come back at 10:30. We'll finish up the rest of this material, which is we're gonna spend a little bit of time on talking about various pathogens and infection, and then end with sterile gown and gloves. And then once we are done that, you guys will start your exam. I'm thinking you should be starting your exam like shortly after 11. Okay, well, your quiz. So you go ahead and take your break, and we'll start back at 10:30.
What you gonna do? Your son got divided in? He got to log in at 1. Oh, I'm late early. Guess somebody bust my walker. Why? Car break-ins. Over there, I remember it was at least 10 cars in my area. In my parking lot. They need to get their gate fixed, put cameras out.
In my apartment complex, they got cameras and they got a gate.
See what I'm saying? They need a gate fixed, they need them cameras up, and they need security.
It's on better.
Well, signing in and all that stuff. So then he was trying to get them to change the
Sorry.
and then he was harassing security, you have to keep them out. And all they're on control of cameras. How do you get kicked out of show?
I know I told you. I know I told you that, like, springtime.
Like, he's
spring,
literally
summertime, about
Yeah, I remember.
okay, so it's we had a conversation.
Yeah, he was not, it was
He
okay.
fixed it.
But he's sitting there working on
No,
student show.
or as a tutor.
Cause that's what they were talking about, they're like, how's he even still working as a student tech, taking up all our hours, he's not even on a program anymore. Then the other techs were like, wait, he's not in a program, he's like, no.
For the little birthday party we had, you can't
But,
have
he also got in trouble at Griffin because he was, doing something during
About
floor
like
exam.
September, I
Like,
noticed
what are
the
you
issue.
doing? He's like, I don't know.
I hadn't really seen him when he was
I
attending
see that.
because
He's,
he came for Thanksgiving.
yeah.
And I was trying to observe him like,
But I was interested to know because,
I'm looking at this.
so the president was the one who told me that
There's
he
like,
said to
he
leave.
comes up
And
here.
then the text told me, you should leave because the tornado was coming through here. And I was like, oh, okay. And then I saw your text message. I'm pretty sure it drove me that damn
And it was
tornado.
a nice,
Like, I'm talking about like, everybody was driving like
so, okay.
2 miles an hour,
I didn't see him
all the
for
rain
Christmas,
and
New
the,
Year's is-
all the trees and the traffic lights were like horizontal. I was like, I'm gonna
So
die.
I seen him this
He
past
about to
week,
sit
actually,
right
I got back yesterday.
seeing like grocery stores destroyed in Griffin. I was like, y'all. It's like the whole Hobby Lobby was torn off, like light poles and all that.
Not to mention you go back to these stops. And so it's funny that the now collectively everything is just,
She's like, why are you down here? And I'm like, why am I down here? That's a good question. She's like,
no, I'm not talking about
50
that.
miles from here. I'm like, 35.
Your average boy. He's not like teenagers.
She was like, oh,
I hate
Anyway,
driving
he's
up
just, he's a boy. He lives
First
out
off, I
by
hate
himself.
going there because
He
they're
just
all-
does whatever.
I'm just going up that way.
Nothing wrong with that.
That ain't gonna.
But when you realize that your loved ones come
I really want to go.
hours and drilling you.
You got 4 in the room. Is it has some gas in here?
He knows I hate hair in the shower.
I'm just
He
like,
like
no.
he gets my chest hair, so when
God,
he's carrying me in the shower,
this
he's carrying me on
is so
That
far
shit
from
drives me the
like
crazy.
literally
I
driving
hate
to
sitting on the
Choa
bathroom floor. If you don't see my hair, it's a bitch with I never want to see it.
and Choa has traffic. It's
So people like,
He
he's
wants
small,
to be better.
or like I will tell him, and I shouldn't have told him.
Why? What did I do? Why was yeah, the children want to get sacrificed and dies and everything, so it's kind of ever after.
That's why I said like.
Yes, I did.
And they said they had a whole conversation.
Right, just like, what are you doing? So his and I've always told him like you do it. Your room must know. He's like, so this past trip drove me wicked. We had Saturday, we had got up, took Shannon to Johnson.
And then it's like, first of all, until Thursday, there's no other students there. And then on Thursday, there's 3 Southern Crescent students
That's
there.
how I am. That's right.
And then one of them is the one I work with that at my job. He was like, oh, my teacher sent me over here to see which one of y'all there accidents. I was like,
Why?
what does it matter? Because that's their site. No other school goes there. I was like, what, y'all come here to judge me, see what I know? I don't know anything, go ahead and just go. If y'all want it. But you know what's funny though? They wanted me to do all the exams because you know Southern Crescent, if they mess up on a
The
comp,
next day,
they have to start all the way back over.
I asked him.
So for all the floor exams, they're like, you can go ahead, do you need those, do you need those? I said, no, I've got them all, but if you need to watch me, go ahead. Since y'all know everything, go ahead and watch me.
So I said,
I
well,
already did this
I'm
so
telling
many
you,
times.
you need to go back 2 days. I said, no, you won't.
I mean, it's not bad. It's a little, I don't wanna say it's,
So I said,
but it's like, it is. Like the people are, it's like weird. I don't know how to describe it. Like I just see some things and I'm just like, this is very illegal. So I'm not gonna say anything. But I feel like everybody's watching like a hawk. Like, how y'all doing portables in a rolling chair in the middle of the hallway? And then the old man almost fell out. Because why would you put it in my little man's rolling chair do it?
his nose got me, bro.
Yeah, I was like, how about that shit was a license I don't have?
All like the rest of the day, was like 3 o'clock. The rest of the day, I was just like in the news.
And then like, there's a, they don't be working, like literally one day we went in there, the equipment down there, the teacher, was just the people,
But we went to the store.
and then it didn't work again, they came and fixed it again. I was like, oh, y'all need to shut the fuck down.
We just drove a while, and the
Oh,
aisle I was
also,
going
one of the,
to,
I don't know
here charging, but it was just sitting over here.
Jasmine, they tripping. Did nobody update you on the pointers I gave about studying and preparing?
Not
This
yet.
morning?
Not yet.
No, Miss
We
Lee
were
gonna
gonna
interview about the, thing, no, they gonna take, your classmates gonna tell you.
Oh, I drove past the school this morning because I was zoned out.
Where you at?
I don't know. But the next thing I knew, I was almost at the other side at 75. I was like, where am I?
It was just sitting there.
I just literally drove right past the school, and then I was like, is that you?
Lenora, you could go get.
I already knew I was in the zone because I didn't even realize I don't even have music in my phone.
You could go, Lenora. I was trying to look for you to tell you.
I'm
Oh, Miss
sorry.
Wallace, my child's not on online grad school, so I just been clocking in as simulation.
Oh, I added it. Try it again. When did you? When did I add it? I think either like late. I was gonna say it might have been late Thursday night or sometime Friday. So when you go tomorrow, check and see if it pops up. Cause I added like 5 of our newer sites in there. And let me know how things are down there from the storms. Because I kind of sent them an email like hoping all was well, and I haven't heard back from anyone.
Well, I saw from the news, and I'm pretty sure I drove
Christmas
through
came
that
up,
tornado.
so.
Oh no.
Because the text told me to go ahead and leave because they said it's gonna get bad. But when I left, I mean, when I saw in the news, a whole bunch of places got torn up.
Yeah.
But I didn't see anything about the hospital.
The hospital is fine.
What y'all talking about?
The roads are clear now. That's why I meant I was all my family members. Like 80% of people have like.
Yeah, 'cause I was telling her I didn't get a response back when I sent that email Thursday night.
Go ahead.
So I didn't know if they were like direct, like the, management and the website and stuff.
I was like,
Another room on the bottom,
Oh, okay.
or on the bottom rolling cart.
Let's call them this afternoon, Jasmine. Let's call them.
Okay.
Yeah, it was bad.
I saw. No, it was like, hey,
Well, glad to say. Glad to say.
I said it from, I'm like,
Yeah, they stated over the announcement at the, at Fred.
I haven't worked that in 2 hours ago.
Huh? It took you 2 hours?
Wait a minute. Cause she wanted to work, you just like.
Sometimes you just need a break, Miss Wallace. I ain't been working 2 weeks too. I ain't got no check coming up.
I don't know the money.
I ain't got no check.
I had to put my car in the shop, you know, so, yeah.
Come Friday.
Emma, how you doing?
Alright.
You alright?
Yeah, I'm very work.
The tree fell on my neighbor's house, but we were good.
Now we done been pathogens. I'll call it pathogens. Oh, thank you. I'll show you. Do you want it? Thank you. Y'all. This chapter 4, your infection control. These chapters are small, considering we got all the compacted information. You going back filling in? I heard you going back filling in. Filling in your notes. I'm just gonna put this video and put it on YouTube. I got a YouTube on my TV. You put the first one on YouTube?
Alright,
I'll
so
put it on
let's
now.
finish up this material. So, gonna talk about different types of infections, disease process, pathogens. Alright, so that's the area that we're heading into now. So the various types of pathogens, there's 4 main areas. that you wanna be familiar with. So we have bacteria, viruses, fungi, and parasitic protozoa. So those are our four main types of pathogens. So you want to be able to differentiate between those four. And now we're going to talk about some terms that come about because of these pathogens that are important to our healthcare industry. So what's the term that we know that we've talked about where you acquire an infection, okay, and typically these various type of pathogens lead to some type of disease process or some type of infection, but which is the one where you obtain an infection while you were under medical treatment or in a hospital?
No,
That's health
no,
related.
Nova Scotia or something like that. Nova Scotia.
You said Nova Scotia. It's nosocomial. Okay.
We were close.
So nosocomial is your health-related infections. So those aren't good things because in a sense we want to be there for the patients to treat them accordingly, make them feel better, not cause them another problem. Okay. So we have a patient that comes in for a compound fracture. They go to surgery, get their fracture repaired, get sutured up, they're recovering in the hospital, and then come to find out they have MRSA, okay? And it was acquired in the hospital. That is an example of a nosocomial type of infection,
Okay.
all right? So we really don't like those, especially the business side of healthcare does not like those because insurances do not cover anything pertaining to those type of infections. We have latrogenic, which is caused by some type of medical exam or treatment. So basically a side effect, all right? And sometimes this can be viewed as some type of negligence if the ordering physician did not realize the potential side effect might impact the patient if they're on a different medication or a different type of treatment. So those are all things that need to be explored thoroughly by the physician. Idiopathic, these are processes that happen and they don't necessarily have a known cause. Okay, it's idiopathic. Now when we look at pathogens and break that down into a more closer lookup, we know that, remember we had a cycle, right? There was a chain of the infection and there's different parts of that chain or that cycle. So first, we need to identify some parts of that chain or cycle. We have the reservoir, all right, which is termed the source of the infection. And we know that infections can occur because of some type of contact. We have direct contact and indirect contact, all right? So here are some examples of direct contact. We have foamite object that is hosts the pathogen, whether it's a bacteria, a virus, a parasite. We have vehicle, which is how that infection is spreading or the mode of transportation, how you contracted that disease process. And then we have vector, okay? Vector is the specific type of bug or pathogen, okay? What is going on? What are you impacted by? So all of those things together, when we look at the whole chain of infection, this is what we're focusing on. These are the four main areas that are going to be on that chain. So you've got your host, okay, or where you're getting that infection from or what type of bug it is. The infectious microorganism, so what type of pathogen specifically are we dealing with? The mode of transportation, and we'll kind of talk about that coming up, because the mode is how we want to be aware and protect ourselves with potential PPEs, depending on what's going on. And then the reservoir, all right? And again, the reservoir is the source of the infection. Some common routes for disease transmission I have on the next slide. Alright, so this is again leading into our PPEs. We know that air, droplet, and contact are the main ways that we're gonna protect ourselves with our personal protective equipment or PPEs. And depending on what category our patients fall into, based on their disease that they have, we are going to protect ourselves for either air precautions, droplet precautions, or contact precautions. So it's important that you are familiar, and you don't have to know every single one of them, but the bloodborne pathogens that we encounter on a more regular basis, you want to be familiar what type of precaution you should be gearing up for with your PPEs, because you don't want to potentially expose yourself because you weren't equipped properly. All right? So what type of route would TB fall in out of those three? Tuberculosis, would it be air, droplet, or contact?
Air. Air.
So TB is an air. Okay. What's an example of droplet?
Like you're coughing and your germs getting somebody viruses, bacteria virus. Yeah.
Flu, even COVID, okay, because we know that COVID is associated with a lot of coughing and you've got the droplets being expelled. Contact. So I mentioned MRSA earlier. So MRSA is an example of a contact type of disease. C. diff. Somebody that? Yes. So that's another one. So these transmissions can be exogenous or endogenous, and usually it's going to be differentiated by vector versus forma. So that's the specific type of bug that are carrying these different pathogens. Looking at healthcare related infections closer, all right, we had initially talked about nosocomial and latrogenic. So latrogenic is the one that's usually a cause of some type of side effect or reaction. Sometimes it could be viewed as negligence. Nosocomial are infections that develop while in the care of a healthcare entity. So we want to be careful of these. Bloodborne pathogens, give me some examples of those.
HIV, HPV.
So those are the first two ones that you guys said, HIV and hepatitis, are the two that we're gonna take
Not
a
HPV,
closer look at right now.
HBV.
So these are disease-causing microorganisms present in human blood, and these two entities will fall under the nosocomial region, and typically the ones that we are going to encounter the most is HIV and hepatitis, all right? So that's part of the reason why you guys have to go through all of that health requirements at the beginning of the program, and you've got to update them as you're in the program every year to protect yourselves against some of these bloodborne pathogens. So with HIV, we know that it impacts the immune system. It can further develop into AIDS, and these are some of the symptoms. Individuals that have this virus can be asymptomatic for quite some time. So depending on your activities, it's recommended that you get tested often for this disease, depending on your lifestyle and your activities and what you're engaging in, because again, you may not have any symptoms and you might not be aware that you even have this virus. When we look at hepatitis B, this is primarily impacting our liver, okay, and the function of the liver. Some individuals that have hepatitis B, depending on its severity, it causes jaundice or yellow skin color, and we see some of the symptoms here. Again, these patients can also remain asymptomatic for quite some time. So with this disease process, it's recommended to get tested and follow up on testing if you know that you've had a high risk potential exposure to hepatitis B. Or we know that certain population, there's a percentage of our population that do not, although we get the hepatitis B shots and it's mandated or required in healthcare entities and professions, Some individuals just do not have that immunity for hepatitis B. Although they get the 3 shots, their immunity does not convert to show that they have enough antibodies present for hepatitis B. So those individuals are a bit at higher risk. So they really want to be cautious when dealing with patients that are known to have hepatitis B. Different defense mechanisms of the body. So we have internal and external mechanisms that help to fight off various pathogens and disease processes. Internal mechanisms are shown up here on the side. We've got mechanical barriers, chemical processes, and cellular processes. When we look at external mechanisms, that is going to be your normal immune system built up in your body. Also added immune systems, immunizations through vaccinations. We have chemotherapeutic agents that will fall under the external mechanism, and then good old hand hygiene. Making sure that you're hand washing frequently is an area of external mechanisms. When we look at standard precautions, again, that's going to be directly related to our PPE or our personal protective equipment. So you want to make sure that you are wearing or donning the appropriate equipment that is needed based on what type of patient you have, what's their disease process, and what's your interaction with that individual. So earlier we talked about the 3 types of precautions, which is going to be airborne droplet contact. So you want to make sure you are wearing your appropriate equipment based on what isolation your patient falls under. Definitely hand wash before and after you go in with the patient. Make sure you're wearing either a gown if deemed to, goggles, a mask, gloves, those type of things based on the precautions. Then we are going to get into asepsis and non-asepsis. Asepsis. So you have 2 areas in your textbook that cover both of these regions. And we're going to spend time specifically on the asepsis portion because that's a little bit more involved. So when we look at asepsis processing, these are some of the areas that we're going to see fall under that. We have surgical and medical asepsis. Again, hand washing is going to fall in there as well. And then chemical and physical methods of asepsis. So asepsis is basically our sterile process, okay? Maintaining sterile environment in the field and sterilization if we are using physical tools or equipment. So these are our pretty standard precautions as far as what we need to do to maintain some type of aseptic environment. And we can go further in depth based on what the procedure is or what the protocol is. So hand washing, gloving, PPE. We know what the use of venipuncture and needles that we do not recap as safety precaution, and how to handle biospills appropriately. With contact precautions, again, we want to make sure that we either are wearing gown, gloves, face mask, goggles. Sometimes our respiratory system might need to be a little bit more protected, especially with those airborne pathogens. So you wouldn't want to just wear a regular surgical mask. For those, you might need to wear some type of respirator. So that's where your N95 mask will come into play, as opposed to just going in there with a surgical mask. So these techniques can be applied regardless of where you are. It's pretty standard process. It doesn't really change up just because you might be at Piedmont Rockdale Hospital as opposed to the VA. these precautions are supposed to be universal across the board. Now, they may be a little bit more in depth, again, depending on the procedure that you're doing. So if you have a patient coming down to you and you're going to do a barium enema exam on them, they're not going to need to have as much sterile involvement as if you're doing a procedure in the OR with surgery, okay? So it's going to vary depending on the procedure that's being done. When we look at surgical type of aseptic, this is where we're really increasing that sterile environment, that sterile awareness and precaution. And same thing with medical asepsis, okay? We want to make sure that we are protecting that individual against infection as much as possible, both before and after surgery. So there's certain processes that are put into place with these individuals. And since we are often in the OR environment, in the OR suite, we want to make sure we're aware of that, okay? Especially when you guys go to the various sites, because we know in the OR, typically there's, marked in the OR, the non-sterile areas versus the sterile areas. You know, you have to have your hair in the hairnet, the booties on your shoes, and you have to be in your sterile scrubs when you're going into those sterile environments and so forth. So you want to be aware of that. Medical asepsis is where we're removing or destructing infected material. So this more so takes place, it's both before and after, because that's where sterilization comes through, and there's different methods of sterilization that can be done just to make sure that the equipment is sterile for use with each patient. We talked about when we're opening like a sterile tray, what's something that we need to check for with the sterile tray before we even open it?
Date.
So expiration date, if there's a broken seal, if there's any punctures, tears, okay, that's really important, because when we're doing hysterosalpingiograms or lumbar punctures, myelograms, all of those procedures typically have a tray that we use. So we want to make sure we're checking for all of those trays to make sure that medical asepsis technique that was done is not jeopardized. Okay, if we see something off, we're not going to continue to use that tray. Where do we fall on the surgical team? Are we a part of that team or no?
Yeah, we're a part of the team, but not. We're a part of the team, but
We
we're non-sterile. Yeah.
Correct. So we're a part of the team, but we're non-sterile part of the team. All right, so you want to go back and look at who are your surgical team members, and also know who is considered sterile and who's non-sterile, all right? Because you don't want to get yourself involved with a sterile person handing something to you and you're non-sterile, now you contaminated it, all right? So know the differences. Also, maintaining your sterile field. So when we're in the sterile environment, is it okay to have your hands down by your side or by your back, behind your back?
No. If you're in a sterile environment,
Above your waist.
above your waist and the front.
So in front of you and above your waist is where you want to have your hands positioned. So you want to be mindful of that. Even though you may not directly be involved handling sterile material or equipment, it's just good practice to have, all right, while in that environment. We utilize sterile draping to help minimize and maintain that sterile environment. So you'll see that when you go in for your various surgical procedures, that the patient is going to be draped. And then we have certain equipment that we will drape on our C-arm to help maintain that sterile environment as well. And usually that's done beforehand, so you want to make sure you're aware of the process of draping. Let's see what else. So here's a quick image of how to establish a drape. So again, that's a little bit out of our practice. We more so don't do that. That's usually the surgical techs that are setting up all that draping in the surgical suite or the OR. but we do participate in having the C-arm drape. Usually, there will be an individual that is going to assist you in draping the C-arm to maintain that sterile environment once it comes closer to the patient or the surgical site. With trays, remember we had you guys all practice opening sterile trays. And again, that's not something that we do on a regular, all the time basis, depending on where you are. But you just want to remember that there is a process to opening a tray. Being mindful that everything that is contained in that tray, once you check the outer packaging, is sterile inside. Okay, so you don't want to cross-contaminate anything. So what are we, if we're opening and dealing with a sterile tray or sterile field, what should we be having on our hands?
Gloves.
So sterile gloves, okay? So remember, there's a proper way of putting on sterile gloves, donning and doffing sterile gloves. So you want to go back through that process. Just be mindful of it. Again, I know it's not something that you guys see on a regular basis, but you just want to be aware of the process and just go back and remind yourselves. Also, with sterile, we also sometimes will assist more so in our departments if the radiologist is coming in and they're doing a hysterosalpingogram and we're assisting them. That tray is going to be sterile, so we have to keep that in mind. You want the radiologist is going to have sterile gloves on, but for the most part, we're just wearing regular gloves. So you want to make sure that the radiologist is taking everything off of that tray. If you feel like they're going to need something or ask you to hand them something, you need to get your sterile gloves on. You don't want to just touch whatever's on the tray with regular gloves, because now you contaminated that tray. What you can do is if they need something that's not on the tray, like let's say they need more cleaning solution, okay? You can pour that out for them and still maintain that sterile environment. Or let's say they need a different size needle or more gauze. You can open the packages. Remember, we practice opening things and popping it into the sterile tray, and then you're still maintaining that sterile environment. Sterile gowning, you want to go, remember, oh, really quick, another important thing with fluids, make sure that you want to pour everything into the container. You don't want to get that drape wet, because if that solution pours out and it gets the drape wet, then that drape is now contaminated. All right. Also, if we are assisting in pouring some type of liquid, you wouldn't just rest the bottle down on the drape, because now that area is contaminated. Okay, so just be careful with that. Gowning, you just want to kind of review the process. We typically don't wear sterile gowns because those are more for individuals that are completely sterile in the field, and we're not sterile individuals. So that would be the surgeon, the nurse will be going through all of that process of putting on a sterile gown. Alright, so that's just more about sterile gown. Okay, and we're just going to end with talking a little bit about some important tips that you want to remember when it comes to portable and the OR. Okay, again, sometimes we have to bring that portable machine into the surgical suite to take various x-rays, and then we have to do that yet. Like just a regular portable into the OR suite. So you want to be mindful of the sterile environment as much as possible. Typically, they don't like us to place the receptor because we're non-sterile, so sometimes they'll put the receptor underneath the patient, and we just kind of tell them and guide them where it needs to be, and hopefully they do a good job of listening so we don't have to do a repeat. But all of that is important when we are coming in to do a portable x-ray. What was the reason someone can tell me that they had to do a portable x-ray in the OR?
They lost count of, they couldn't find one of the instruments that they didn't, or whatever, when they did the end count, they couldn't find something.
that's a pretty common one. Before they do any type of surgery and actually start the surgery, they always count all of the tools and instruments that are being utilized, and if that count is off at the end, they will call us to make sure that they didn't leave something in the patient before they close up. Sometimes emergency surgeries, they don't have time to do a count, so they'll just use us at the end. Okay, just make sure there's nothing in the patient before we close, and then they're good to go. All right, so that's a pretty common reason why we are oftentimes used in the surgery for portables. We talked about the CR draping already, so again, make sure that you have someone, a part of the surgical team, assisting you in appropriately draping the CR. Tell me about some of y'all experiences in dealing with our neonatal population for portables.
Usually their bed has a little tray.
Tray, yeah.
With the trees laid in.
Everybody in there's hostile, but I get it, I guess. If you turned up.
So, you're talking about as far as the staff?
Yeah,
Okay.
especially like the respiratory people, they're real.
Mm-hmm. So, how is the tray helpful to us?
We don't have to
We'll
touch
have to
the
touch
the baby.
Yep, so it minimizes our direct hands-on with the baby. Also, that's another barrier with these individuals because they're usually the preemies, you know, depending on what weeks gestation age they were born at, their immune system is compromised. So we want to be mindful of that. So we don't want to introduce any outside pathogens to the little one. So by using the tray, that avoids that hands-on direct contact. And if we do have to move a baby, what's the appropriate way to go about that? Like, let's say you need to do a chest x-ray, which we pretty much typically do with the patient supine or facing up, but the baby, when you go, is laying on their tummy.
Get the nurse.
Yeah. Yeah, so we're gonna have the nurse turn the baby, and like Jalen pointed out, they're probably gonna be annoyed with you, because they're probably doing a bunch of other things, and now they gotta turn the baby, if the baby's intubated, they're gonna have respiratory there to assist and watch that line. But we gotta do what we need to, but we would never take it upon ourselves to just do that on our own. These babies, a lot of times they have daily x-rays done, sometimes multiple times throughout the day for various reasons. So we've got two listed up here, tachypnea and then RDS. RDS was recently on the rise. I'm not sure how it is right now, but a lot of pediatrics were being impacted by RDS. So, you know, depending on what's going on with them, they're gonna have a lot of x-rays done. So are they completely not shielding the babies as well?
Sometimes, it's like, sometimes.
They're not showing the babies if they in a little container.
I noticed that the baby should stay in NICU. Some will and some won't, but we'll always ask, and they're like,
They're not shielding?
They're not shielding. Not the babies.
They kind of shield
They-
occasionally, like,
But if they're in
like
that,
text discretion.
if they're in that container,
Not that
they may
you
try to
get,
collimate real tight, but
Yeah, they call them maybe.
Okay, I was just curious, I wasn't sure, because we had that whole, campaign that came out, Image Wisely, Image Gently, and that was all just around the whole pediatric population, but I guess that's gonna kind of be, done with for a little bit, but, we're still gonna talk about shielding because it's still in our content and they haven't removed it yet, so we wanna make sure that you're aware of it, so.
yeah, but it's mainly just from what I seen, the neonates.
Mhm.
but my thing is, like, I get that they're saying shielding is phasing out, but usually, like, that population that we x-ray that we don't shield, we're not x-raying them every day. But these babies get like x-rays
babies are
multiple
not.
days,
Yeah, the
you know,
babies
so I
are.
feel like we would try to shield them more since it's multiple times a day, every day, but.
Ain't.
We still are not.
Well, yeah, we're still gonna have it in our curriculum until, like, the ASRT or the ART completely remove it, we're still gonna have it a part of our curriculum as far as children. Alright, so I think that's, pretty it, at the tail, yeah, just at the tail end of the presentation, there was just a couple of like little quiz questions as far as the ranges and stuff like that, so you guys can take a look at that if you want for your upcoming weekend test. But that was pretty much the material for introduction to radiology and patient care. Right, so again, we didn't hit on every specific thing that is in the textbook, because we just don't have enough time to cover all of that, because remember, this material is taught over a 16-week course, so we're just kind of doing a crash course run through, so make sure, like Ms. Wallace gave you guys the tip of breaking down that handout with the content specifications and just really reviewing on those areas that are listed in there. And if you know that you're pretty strong in some of those areas that are listed, you know, go to the ones that you just completely forgot about. I would start there, so you are becoming more familiar with it and you can retain that information.